Ready when you are, Lucien.
Thank you, Karen. Good afternoon, everybody. My name is Lucien Ferndale. I'm a surgeon working at Gray's Hospital in Pietermaritzburg, and I'm going to be talking today about esophageal cancer. Karen, can you see my slide?
Yes, I can.
Okay, thanks. Okay, so esophageal cancer is a bit tricky because not everybody deals with it. In our center, we deal with it, so it falls under the gastrointestinal surgeons, but in many centers it falls under cardiothoracic surgeons. So it's one of those areas that they're not consistently falling under one roof, and that makes it a bit tricky. Many people don't know much about it. Many people are not sure whether they should know anything about it. So, but we'll see. From as far as I know, Dr. Skriba, Matt Skriba is the one fellow that's shown interest in GI, upper GI. So I'll be asking most of my questions to him, or directing most of my questions to him. If anybody else also has an interest and would like some questions asked to them, they're welcome to let me know. You can just say so, or put up your hand up, or whatever, and then I will also go to you. Otherwise, I'll focus most of my questions on Matt. Welcome to everybody. As you can see on the slide there, this is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. It runs every Monday at 16:30, and the chat will be open for questions. Okay, so let's just run right into it. Just an introduction. I call it as a top 10 cancer because worldwide, it's but the 8th commonest cancer and the 6th commonest cause of cancer deaths. In South Africa, it's the 2nd commonest cause of cancer-related deaths in men. So it's a very common cancer, and it causes lots of deaths. So it's quite a relevant cancer. In South Africa, we need to know about it. There are lots of problems with this, apart from the fact that not all centers deal with it in the same way. And one of them is that there are 2 biologically distinct types, and they have just divergent epidemiological routes that they follow. This has hampered accumulation of evidence for this disease. And you will see why. I'll show more why as I'm doing this talk. But of the 2 types, adenocarcinoma and squamous is the commonest one in South Africa, predominant one. And really, it's only common in certain areas in South Africa. That's the Eastern Cape and KwaZulu-Natal. Patients are seen in Gauteng and Western Cape, but these are mostly patients that come from these other 2 areas. It's dreaded disease that's common there. And these 2 areas, they fall in a specific esophageal cancer corridor that runs along the east coast of Africa. The other thing that's difficult with this cancer is it's just associated with the late presentation. So less than 20% worldwide of patients are eligible for curative treatment, and this figure is even less than 5% in South Africa. So all these issues make it a very difficult cancer to manage. I'm just going to start by doing away with the diagnosis because it's not always clear how you diagnose the disease. But weight loss and dysphagia are the cardinal symptoms. So if you get those 2, you must immediately think of esophageal cancer. This might sound obvious, but you'll be surprised how many patients present with weight loss and dysphagia to medical practitioners or healthcare professionals, and they don't think about esophageal cancer. And this is one of the reasons for late presentation. But anyway, the other reason for late presentation is that the esophagus expands. So as the tumor grows, because of no serosa, the esophagus just expands to accommodate the tumor, and the symptoms come late, and they're locally advanced at the time. But the gold standard for diagnosing the disease is endoscopy with a biopsy. And when you do a scope and you see a tumor in the esophagus, you must mention the exact site. You must mention the length of the tumor as measured by an endoscope. Your exact site is according to the distance from the incisors. You must mention whether it's circumferential or not, whether it's causing obstruction. And there's evidence that shows that you should take at least 6 biopsies because that increases the chance of yield to acceptable levels. So these are just principles to follow. But what we're going to really concentrate on first is staging. And I'm really going to talk today, because of time constraints, you can't do anything. It's a vast disease to discuss. I'm going to talk about staging, and I'm going to talk about early cancer and then some surgical principles. I'm going to leave locally advanced cancer out of it and metastatic cancer out of it. That can be done as a separate talk. Otherwise, I just won't do it justice. Right. So let's talk about a clinical scenario so we can start with the interaction. So a 56-year-old female, this is a patient that presented with dysphagia and weight loss with no comorbidities, ECOG1. The upper endoscopy shows a tumor that is 28 to 34 centimeters from the incisors. You can see which part of the esophagus is in. That's round about the mid-esophagus. It is, as you can see, 6 centimeters long. You biopsy this one, and the pathologist tells you this squamous cell carcinoma. Now, the question that I have, and this one is for Matt, with regards to the staging investigations for this patient, okay, which of these statements are true and which are false, you can say? Now, the first statement, end stage, which is nodal stage, is defined by the number rather than the location of nodes. Matt, do you think it's true or false?
Yes, that's true. Certainly with the pathological staging, yes.
That's true. We'll go into that and show you why. Endoscopic ultrasound is superior to CT scan for nodal staging. True or false?
I would say that's false.
Okay, so yeah. We're warming up now. Good. Getting fast, getting better. Right. They'll get harder. Endoscopic ultrasound is least accurate for T stage in T2 lesions. You think it's true or false?
I think that's false.
EU is least accurate for T stage in 2 lesions. It's true. I'll show you.
Okay.
Hey, right. The specificity for CT scan for nodal staging is superior to EUS. True or false?
The specificity. Yes, I think that's true.
True, good. And a barium swallow should be performed to exclude a tracheoesophageal fistula or some axis deviation or angulation. True or false?
It's certainly useful. It's certainly useful, but I don't think it should be performed in every case. I want to say false.
Good, false. Right, good. So they wonder we struggle with the EUS for T staging. Let's see. We use the international staging system. This is a popular picture that's put up that it's actually very nice, that shows how you stage the cancer, making it easy, where the M staging is simple, it's whether there's metastasis or not. And the node staging is related to the number of nodes rather than the location of the nodes. It used to be according to the location, but we use numbers now, so that has changed. And the main differences, we use the 8th edition. The main differences for the 8th edition is that the T1 has been changed to T1 AOB, whether it's in the submucosa or not. And T4 has been changed to T4 AOB, whether you can remove it or not. So the modalities we use for staging are listed here. Everybody knows about CT scan. And in the US, there's some debatable issues. PET scans, there's debatable issues. Endoscopic mucosal resection or submucosal dissection is used and can be part of the staging. And then there are others that are used, not routinely, but sometimes only. The latest version of the NCCN will show you all the workup that you need to do. It includes the physical examination, GI endoscopy, talks about CT. It doesn't mention anything about barium swallow. And barium swallow has really fallen out of routine use for esophageal cancer. It's just not worth the effort anymore. The amount of information that you gain from it in today's world, it's really doesn't make it worth it. So we don't use barium swallow at all any longer. So that was true, but they do say things like PET scan if no evidence of M1 disease, and endoscopic ultrasound if no evidence of M1 disease. We'll go into more detail of when you should use those two. Okay. So we did answer the N number of disease. Let's talk about the other things. When looking at endoscopic ultrasound, the evidence we can use is from a meta-analysis done by this group from China, which, as you can see here, when they compared EUS and CT scan for T staging, T staging, that's the tumor itself, they did find it to be superior to the CT scan. So EUS is certainly superior to CT scan for T staging. Okay, so that you can answer as yes if that's asked. However, if you look specifically at the staging down here, you can see the T staging alone. That T2 staging has got the least sensitivity, the lowest sensitivity, and the lowest specificity. So it is least accurate for T2 staging. And the reason for that is because when you perform an endoscopic ultrasound, you're going to have to look at two areas, two borders when you're looking for T2. Whereas for T1, you look only at, you've got the lumen and then the border is at T2 level, which is beyond the submucosa to the muscle. And when you're doing T4, then obviously you're going through the esophagus, T3 and T4. So they are more accurate. Whereas the T2 stage, you need to know where T1 ends first. So that you need to know where the submucosa is in relation to the muscle. And then you need to know on the other side where the serosa is, I mean, where the, sorry, where the adventitia is compared to the muscle. And that makes it harder to see. So they found in that meta-analysis that T2 staging is actually the least accurate for EUS. Okay, what about nodal staging? The evidence we get here is from another meta-analysis done by another group. And they basically, if you just concentrate on this area where they look at regional lymph nodes, you can see that although endoscopic ultrasound is more sensitive than CT scan or PET scan for regional nodal metastases, its specificity is much lower. And so therefore, when they looked at the three modalities and they looked at the receiver operating characteristic curves, they found that between EUS, PET, and CT, there was not a significant difference between the accuracy in actually determining nodal status. So EUS, yes, is superior to CT for end stage, but I mean for T stage, but not for end stage. Okay, let's go on to another clinical scenario. This is a 60-year-old male now. So once again, the same cardinal symptoms, no comorbidities, good performance status. This tumor is similar to the last one. Also SCC and histo. Okay. You do a CT staging CT scan and you find that, I didn't bring the whole CT scan here, just this is all you need to see. You can see here that this tumor already below the carina, and it's thickened the esophageal wall with a narrowed lumen, and that it looks like there's actually a plane of separation between your tumor and the heart and the aorta. Okay, there's a small lymph node next to the esophagus here. This was too small to characterize, so we're not sure what this is. Anyway, the radiologist tells you that this is either T2 to T3, N node, M node. Okay, so what would you want to do next for this patient, Matt?
I think a PET scan is not unreasonable in this case.
And why do you want to do a PET scan?
I want to specifically see if there are any nodes that lie outside my field of resection, so distant nodes more than anything.
Any other information you want for your PET scan?
You can also see whether there's distant metastases, so not just nodes, but other metastases that you don't see on your CT. Okay. And you also want to see whether the tumor is FDG avid. You don't get a lot of information about the tumor itself on the PET, but it can give you some idea.
What are the chances of having metastatic nodes distant from the tumor in a mid-esophageal tumor, squamous cell carcinoma, do you think?
It's reason the chance is reasonable. It's not uncommon. I would say something like 20 to 30%, depending obviously on the T stage of the tumor, etc. Okay.
Okay, so the question is this adequate staging? And the answer is no, this would not be adequate staging. So you're right. Let's talk about PET and endoscopic ultrasound in a patient like this. In this kind of like decision theory paper, they really looked at whether endoscopic ultrasound or PET scan adds any information to patients that have been staged with CT scan for esophagus. And they concluded, and we'll show their stat number, they concluded that although EUS provided additional information on the T and N category, the risk outweighed the benefit if you had T2 to T4 disease on CT. they were looking at a lot of adenocarcinomas, so they found that laparoscopy was justified for distal tumors, T2 and greater. But the important information here from the conclusion I want you to take is that the risk for EUS just jumps when the tumor is T2 to T4 compared to T1, and it's a question of whether it outweighs the benefit. They therefore said that a CT-guided algorithm would put EUS only for T1 tumors on CT scan, or possible T1 CT scan. When they found, of the 128, they found that, yes, the actual, only 38% of these were actual T1 tumors. But when CT showed it to be T2 or T4B, like the one we saw, then there was hardly any patients that were T1, where EUS or endoscopic procedures would work. So because of this low number, it really, if you think it's T2 and CT already, then EUS doesn't seem to make much sense. And it's mostly for the T stage. So the question they asked is there any point in performing an EUS if you've got a T2 to T4 lesion on CT? The answer is that it's still debatable, but I can tell you that for us, we don't ask for it, and it looks, and we feel that the risk does outweigh the benefit. It must be something we suspect to be T1 only, because those are the patients that are suitable for endoscopic therapy. This is just a simple multiple choice question. Which of these investigations are most accurate for distant metastases? Matt, we'll just stay with you. No one else has put their hand up.
I think it's PET. I would say most accurate.
Most accurate. So if you get a multiple choice question like that, the answer is PET. Okay. That comes from this meta-analysis, where the same one where we looked at the EUS. When they looked for distant metastases, as you can see here, PET was both more sensitive and as well as equally specific to CT scans. And when they did the receiver operating curve, they found PET to be significantly better. And they found, this study, meta-analysis, found that it picks up 15% more patients with distant mets. So you could take, there's 15% of the patients that you would diagnose as M0 on CT will come up with mets at laparotomy or even post-op. So yes, PET scan is useful if you are going to, if you suspect a tumor, if your CT scan is negative for mets and is more than T1. So given that information that we have, what we recommend as a staging algorithm for patients, initial staging algorithm would be, you get your dysphagia, weight loss, cardinal symptoms. Those patients all should have an upper endoscopy. Anybody with dysphagia or weight loss should have an upper endoscopy. Not to do so would be criminal. If you find cancer with advanced disease or poor performance status, which is ECOG more than 2, which means they mostly bedridden most of the time. If you find any of that, then they will be for palliation, really. You can't do much. Even the oncological treatments for someone with an ECOG of 3 for esophageal cancer is, you need to be quite strong. But anything other than that, you will do with staging CT. If staging CT shows distant mets, then they should be palliated. However, if there's no indication to palliate the patient, then your CT depends, what you do after your CT depends on what you think. If you think this possibility is T1 on CT, and I can tell you that most of the time you actually won't see anything on CT. So you find a tumor, you don't see anything on CT, so you think it's possible T1, those patients should have an endoscopic ultrasound. And the worthwhile ultrafine needle aspirate, if possible, remember, if you're going to FNA, you're going to FNA in regional nodes, and you shouldn't go through the tumor to do it. So only if it's possible. If you think it's still T1 after endoscopic ultrasound, then you should do an endoscopic resection, which is then at that stage a staging endoscopic resection. If that confirms that it's a T1A lesion, the pathologist tells you the tumor is limited to mucosa, then you can just follow up the patient. If though the pathologist tells you, or your endoscopic ultrasonographer tells you that this is a T1B lesion, and either of them can tell you, or it's N1 lesion, then you treat them the same as anything as a T2 to T4. In other words, they all should have a PET scan. And the PET scan, if, like I said, the CT showed no signs of distant disease, can pick up a further 15% of patients that will have distant disease. Okay, so that's basically the basic algorithm for patients. If you get tumors that's high, they need bronchoscopy, but only high ones, And according to most studies, if it's OD junction tumor, they should have a staging laparoscopy as part of the staging, which you can do at the time of the curative surgery or before you even give them chemotherapy, which a lot of centers do now. Okay, that is the algorithm for the workup. That's all that I'm able to cover in workup. We're going to talk now about how you manage, and we're going to manage really according to the stage. Now, the stages include early cancer, T2 disease, which is one specific area in its own, and then locally advanced and metastatic. The locally advanced and metastatic belongs to another talk we're not going to cover today. So we're just going to talk about early cancer and T2 disease. Okay, so early cancer. Here's our next clinical scenario. This is a scope for a 70-year-old male. He had reflux symptoms. Okay. He was ECOG 1, so he's decent. His upper endoscopy shows this, and your biopsy systems come back as adenocarcinoma. The CT shows no lesion, and you ask for an endoscopic ultrasound. It shows that it is a T1A lesion. Okay, now Matt, what would be your management for this patient?
An EMR or an ESD. In my hands, an EMR.
Okay, good. Yes, you do an endoscopic resection for this patient. So that's fine. You do your endoscopic resection, and let's say you do it as ESD. You try your best to take everything out, and the pathologist tells you it actually is a T1B lesion. They found tumor spread into the submucosa, but you've completely excised it. Now what?
Yeah, I think this is a difficult one, but I think the concern with T1B, as you go deep into the submucosa, your lymph node positivity rate increases significantly. So I think I would then further stage, I would stage this patient with a PET.
You do a PET scan. Okay, good. Okay, so you do the PET scan because we did say T1B, you do the PET scan. The PET scan shows no distant metastases. And they don't show any lymph nodes that they're worried about.
So I think more recently, we've also subdivided the submucosal stage into layers, so SM1, 2, and 3. And if it's very high up in the submucosa and there's no other concerning features on your histology like lymphovascular invasion, etc., you can consider that your resection has been complete and you don't need to do anything more. If there's any concerning features, you have to consider an esophagectomy.
Okay, would
with neoadjuvant, sorry, with going through an MDT with neoadjuvant therapy first, of course.
Okay, would your answer change if it was squamous cell carcinoma instead of the adeno?
Yes, it would, because squamous cell carcinomas tend to be more aggressive and more readily metastasize. So yes, it would. I think a T1B squamous cell carcinoma, I would not consider anything other than taking it through an MDT neoadjuvant therapy and curative surgery.
Good, that was an excellent answer. So on that note, let's see if you can answer the true or false ones. Once again, but your answer, like I said, was completely correct. So keep that in mind. Nodal spread is the strongest predictive survival post-esophagectomy in early esophageal cancer, true or false?
I think that's probably true.
Good. The chance of lymph spread is higher with SCC than adenocarcinoma and T1B lesions.
Definitely yes.
You already answered that. Endoscopic resection is associated with high recurrence compared to surgery in T1A lesions. Now, this is T1A now. Will you get a high recurrence with endoscopic?
I don't think there's evidence for that, as far as I know.
Okay, okay, we'll see. I'll show you. EUS is mandatory in all patients considered for endoscopic resection.
I'm not sure. I'm going to say false. I don't know what the guidelines say, but I think you can.
That'll be true. Yeah, you're gonna have to do because, like I said, most of the time the CT won't show you anything in these early patients. So you have to do an EUS just to confirm that they are, and also you will see whether it's T1A or T1B. And the endoscopic ultrasound may tell you that before you go and fiddle with the lesion. Anyway, but your answers were very good because the early esophageal cancer is T1A or T1B N0 always. Yeah. As soon as you got N1, then it's no longer early esophageal cancer. Okay, and as soon as you got obviously T2, it's no longer early. And This is it's not a picture this is from the internet. It shows that the T1 lesion can be limited. You can see the layers of the wall very clearly. It's labeled here. You can see that the mucosa you can see, and then you can see the muscularis mucosa quite clearly, and then submucosa. So that's how they detect T1A. You see this, it's T1A, and this one can be subjected to endoscopic resection. Okay. Yes, most of the studies done for early esophageal cancer is done in patients with Barrett's and adenocarcinoma. The AGA guidelines does say that BET stands for Barrett's endoscopic therapy. It's preferred over esophagectomy if you've got T1A lesions. So you should definitely say you want to do endoscopic rather than esophagectomy. And in this meta-analysis for endotherapy, looking at Barrett's neoplasia, T1A lesions mostly, they did find that recurrence of the cancer was higher if you did endoscopic resection compared to surgery, but the survival was equivalent between the two. And the esophagectomy patients had more significant, more adverse events. So they did concede, yes, you'll get more recurrence, but your survival is still the same. And for these patients, it is actually better to do the endoscopic resection because of the increased risk of major adverse events. Okay, so the end stage that you answered about the thing is definitely is the biggest prognostic value. So these are patients that they all had early cancer. They all thought it's N0. The patients that were actually N0 had a significantly better survival than those that were N1. The T1A lesions, survival, once again, another study showing that whether you do EMR or esophagectomy, survival is equivalent. So you definitely can do just EMR. In T1B lesions, you don't get the same study because the T1B lesions, it wouldn't be ethical to do a study where you just do EMR on some patients. So, but what they did is they did extended radical esophagectomy and they did less radical esophagectomy. And they did show survival is significantly affected. So, and this is obviously because of the inadequate lymphadenectomy, etc. So if you got T1B lesion, these patients actually need the full treatment with neoadjuvant and with or without neoadjuvant, but definitely they need a esophagectomy. Okay, what also this group that looked at the risk of lymph node metastasis showed, as you mentioned, the different layers of the submucosa. They also showed, incidentally, the mucosa has also got different layers. You need quite experienced pathologists to tell you where this tumor exactly is. And they looked at exactly the risk of lymph node spread. And as you can see by the table here, that if there is some one lesions for adenocarcinoma, the risk is only 6%. So definitely you'd be justified in doing in observing a patient with a submucosal lesion if it's an SM1 and it's adenocarcinoma. Anything else makes it much trickier. If it's gone all the way to SM3, for both squamous and adeno, the chance of lymph node spread is 50%. That's much too high to leave, I would say. And those patients, you should offer them, provided they're fit enough, in a esophagectomy or resection with or without adjuvant and neoadjuvant treatment. Squamous cell carcinoma, as you can see, had a much higher risk. So there's good evidence that squamous carcinoma metastasizes to the lymph nodes much earlier, even in SM1 lesions, 27%. And that is also simply too high to leave. And what I would say is if I got squamous cell carcinoma and a patient is fit for esophagectomy, you're in a center that does esophagectomies, this patient should undergo an esophagectomy. Okay, the only one that you can leave is the SM1 adenocarcinoma. Leaving you with this algorithm for early esophageal cancer, given the evidence. Okay, we didn't discuss in situ disease, but they can be endoscopically resected. The T1As can all be endoscopically resected. If you got T1B, and it's adenocarcinoma, then the SM1 can have endoscopic resection. Most of the time, you're only going to find this out after you've resected it. But you get some very experienced endoscopic ultrasonographers in experienced centers that only look at esophagus, and they can tell you that it's most likely going to be SM1, and those ones you can go on to resect. Only if it's adenocarcinoma. If it's SCC, it goes to esophagectomy, or if you think it might be SM2, SM3, it goes to esophagectomy. And some people, like I said, they go with the endoscopic resection first, and if it's gone to those layers pathologically, histologically, then they'll go to esophagectomy thereafter. And that's the algorithm we just follow for early esophageal cancer. Okay, and there's good evidence for all of those. Okay, let's move on to the next scenario right now. Once again, this is about a 60-year-old male. That's about the average age we see. Okay, they've got this, cardinal symptoms, no comorbidities, fit patient. Tumor, same, this is the same patient, by the way. SCC and histo, the same patient I presented last time. But, because that's the CT you remember seeing, but they sent this patient for endoscopic ultrasound. And the endoscopic ultrasound shows that it's actually a T2 lesion. So after doing an endoscopic ultrasound, they clinically diagnosed the patient, staged the patient as a T2 N0 M0. How would you manage this patient, Matt?
This patient needs to go to an MDT, and
Right.
I would strongly advocate that the patient gets neoadjuvant chemoradiation, and then consider an esophagectomy if they remain fit.
Okay, would you consider doing an esophagectomy without neoadjuvant chemoradiation?
Yeah, that's controversial, I think. I would prefer it if they get chemoradiation. It looks like quite a largish T2 tumor on the CT.
Okay, so if it is a smaller tumor,
I think it needs. My answer is going to be I would discuss it at the MDT and make it on an individualized patient basis.
okay. So if the pathologist and or the oncologist, mostly it would be radiologists, they say, well, you know, this is T2, it's not a very big lesion. We leave it up to you. You want to whip this thing out and see what happens, or do you want us to give him treatment? You make the call. What did you say?
I want to give them treatment.
Okay, good. Right, so you can do neoadjuvant therapy followed by surgery, but there's also the option of doing surgery first and only giving adjuvant chemoradiotherapy if indicated on the pathological staging. And what do you think of the chances of lymph node spread if the patient is clinically T2 N0? So clinically means you've staged fully with endoscopic ultrasound, CT scan, and PET scan. What do you think the chances of it, of having positive lymph nodes if you remove the esophagus?
Well, I already know from the T1B SM3 that it's almost 60%. So with a T2 lesion, we're looking at 60% plus, 60 to 70%.
Yeah, it was 50% on T1B, and it's about the same on T2. So for this patient, tumor was 26 to 32. What surgical approach would you use? Say you give neoadjuvant therapy, what surgery would you do? In other words, would you do transhiatal versus transthoracic, and would you do 3 incision or 2 incision?
I would not do a transhiatal. I would do a transthoracic, and in my hands, I would do a cervical. I do a 3-stage operation.
Okay, good. The transthoracic 3 stages in perfect, exactly what I would say. Now, T2 cancers, and the reason why I'm specifically dwelling on this one as basically the final cancer we're going to talk about today, is because it's got a lot of difficulties associated with it. People don't realize. One, it's what is defined as invasion of the muscle, but there's only a small subset of patients that have pure T2 lesions. And staging modalities in general are less accurate. That includes that across the board, CT, PET, and EUS. And I explained why the EUS struggles with it, because it has to see both borders, and it has to see the tumor in relation to both borders, that being the mucosa or the muscularis mucosa. And on the other side, it has to see the border between the muscle, the muscularis propria, and the adventitia. And that increases the level of difficulty. So really only in centers where endoscopic ultrasonographers are doing only esophageal endoscopic ultrasound can they really see this accurately. And we talked about the rate of nodal positivity as in the evidence, and then, but still the positive predictive value of the clinical staging is quite low. Okay, so the management is actually controversial, and one of the reasons is because it's so difficult to stage. So in this group from America looked at T2, T3 lesions on clinical staging, and they looked, what's the risk of node positive disease? So they moved them all. And you can see here that they found that for patients that were clinically stage T2 N0, only 45% was actually N0. And 55%, like you said, more than 50% was positive nodes. Okay, T3 was even worse, but we won't talk about that. We're just talking about T2 lesions now. So staging is very difficult. Even there were some patients, 22% of the patients were actually T1. So you can see how much difficulty they had. They did find, though, that the patients with the positive nodes, once again, did much worse than the ones that were node negative. So the nodal spread was still the strongest predictor of survival. But interestingly, this other group that looked at patients with T2N0 lesions, they did either a salvagectomy or they did neoadjuvant therapy, found no difference. And overall, they had a 50% 5-year survival. And they found that more than 50% of the patients were actually understaged. In fact, they had T3 lesions. Some had positive nodes. But the 5-year survival was equivalent between the two, whether you give neoadjuvant therapy or not. And that is specifically for this group. So it's not locally advanced disease. And that's why they're a unique group. So actually, your treatment options for T2 cancers are either neoadjuvant therapy or surgery. And then you say, you'll only give adjuvant therapy if the pathological stage shows it to be higher than T2N0. And that is an acceptable approach. So the neoadjuvant therapy for surgery is a growing practice, but it's not fully supported by the literature for T2 lesions specifically. But they get good survivals, 5-year survivals, 58%. This article advocated for the neoadjuvant for surgery in 2011, and they showed that survival. But surgery with adjuvant is actually common practice in a lot of centers, because you must also remember a lot of centers don't have they don't readily have access to radiotherapy, and radiotherapy is key with squamous cell carcinoma. But they commonly upstage the patient and then give the adjuvant therapy. And if you give the adjuvant therapy, you actually can get improved survival over patients that you don't give the adjuvant therapy, which is up to 43%. And is advocated by this group that tried surgery with adjuvant therapy as well. So you actually have 2 treatment options for T2 lesions. Okay, let's move on to, like I said, I'm not going to go to locally advanced. We can do that another time if the need arises, but I just want to talk about some surgical principles, because we did ask you a question on surgery as well. And the surgical principles that you should answer is, when you do a salvagectomy, what margins should you aim for? What lymphadenectomy should you perform? And are there differences? You say you wouldn't do transhiatal in survival or any complications with the 2 approaches. So the first question of margins, when you do a salvagectomy for T2 lesion or any esophageal cancer, what margins should you aim for, Matt?
I've always been taught to try and get 10 centimeters up and 5 centimeters down. But in the end, if you've got a tumor-free margin on histology, then you're happy, an R0 resection.
And do you know why they ask for such a large margin of 10 centimeters?
Yeah, because in esophageal cancer, the spread is often submucosal via the lymphatics, and it can go quite high up and down, even though you have quite a small localized tumor. So the lymph nodes can be quite far away. So I think it's based on that.
Okay. Okay, what extent of lymphadenectomy should you perform?
There's been debate regarding a 2-field or a 3-field. I think most centers, and certainly what I would do is a 2-field lymphadenectomy, so that doesn't include the neck and the medius and the superior mediastinum in a patient like this. If it's a very high tumor, that's different, but then we're talking about patients where you might be considering definitive chemoradiation. But I would do a 2-field, so I do the chest up to the level of the carina, and then like a modified D2 in the abdomen. Okay,
that's pretty good. And then between transhiatal and transthoracic, you weren't keen on transhiatal. Is there a difference in survival if you do the 2 for, say, T2 lesions?
Yeah, I'm not sure what the literature shows, but I think the difference is with transhiatal, you really struggle to get lymph nodes. You do much better from a lymphadenectomy point of view when you do transthoracic. That's the main advantage. Whether that improves survival, I'm not sure on. Just because you take the nodes out doesn't necessarily mean the patient lives longer. So I'm not sure, but I would say to get a better lymph node yield, which is important for prognostication, I would do transthoracic.
Okay. What's the difference in complications between the two, or is there a difference?
There is a difference.
Major
The major complications with transthoracic are respiratory related, pneumonias, etc., and they're quite significant. And you get less with transhiatal. You certainly do.
Okay, anastomotic leak.
I don't know if there's a difference. With a transhiatal, you'd have to go up into the neck. I don't really know how you do a transhiatal and do the anastomosis in the chest. So there might be a difference if you do a two-stage transthoracic versus a transhiatal with the anastomosis in the neck. There might be a difference there, but I think the technique doesn't make a difference.
Okay, so the old adage is the same. We were taught that if you do the anastomosis in the neck, there's a higher rate of anastomotic leak, but it can be managed in an easier fashion than a intrathoracic anastomosis, they used to say.
Yes.
And we were taught that, but that's not based on good evidence. So the anastomotic leak rate is actually equal, and so is the blood loss. Okay, so you said 10 centimeter proximal margin. The evidence for 10 centimeter proximal margin comes from a 1987 study that was done when this group, they did a esophagectomy for patients, and they measured the margin, the proximal margin, intraoperatively, and they found that the rate of anastomotic recurrence, and then they followed the patient up to anastomotic recurrence, the rate of anastomotic recurrence was lowest if the lesion, if your proximal margin was 10 centimeters away from the tumor. It was 0, and anything smaller than that resulted in a recurrence, with the highest being with a 0 to 2 centimeter margin. We get a 25% recurrence, as you can see by that graph. So the 10 centimeter comes from that study. That's where we use it. But as you can imagine, this is not great evidence, and it's a very old study, and I can assure you they didn't use the modern treatment modalities that we have today. So really, we're basing on old evidence and probably shouldn't. So 10 centimeters, it's still used by esophageal surgeons, but they don't have great evidence. There was one analysis done later on in 2014 when they looked at margins that are suggested by different authors, and they found different results with a mean of 8.5 they got, but they found that as you became more modern, the margins decreased in size, and that makes sense because the treatment, the neoadjuvant treatment or the adjuvant treatment, they all improved, and the post-operative treatment, ICU, etc., all improved. So the margin of 10 centimeters is not really based on good evidence, as you can say, and really you can choose, it's surgeon dependent. So we don't actually aim for a 10 centimeter margin ourselves, but it looks like at least you should have a 5 centimeter margin. But you can argue for your 10. For the distal margin, for most gastrointestinal cancers, when we talk about esophagus, the stomach, intestines, the large bowel, etc., they do go for 5 centimeters in general. This group with Oringer, it's a retrospective study, but it was done with 1,000 patients, and they found the lowest recurrence when they had a 4 to 6 centimeter distal margin. So it's pretty good evidence that you need at least 5 centimeters distally. So yes, you can say 5 centimeters distally. Whether you use a 3-field to 2-field is controversial, as you mentioned, and there's few meta-analyses done, and most of them are done from in the East, and the ones in the East mostly will show that the 3-field lymphadenectomy is associated with improved 5-year overall survival. So you'll see that most surgeons from the East will recommend, Japanese and Chinese surgeons will recommend that you do a 3-field lymphadenectomy. But if you really analyze all the studies, the meta-analysis, you find that there was significant heterogeneity amongst the studies. Most of them were observational studies, so the surgeon was someone who does this 3-field. There was lots of bias with these studies, and in the end, it should be individualized. And in fact, studies done in the West points to the fact that the improved survival that you see here might just be perceived survival, not true survival, because it's related to stage migration. So they are actually upstaging their patients by taking more lymph nodes out. And because their patients are a higher stage, but they have the same survival as patients with a lower stage in the West, because they took out less lymph nodes, it looks like their survival is better, which is not true. So it's not a true survival benefit. So yes, you can say there's level 1 evidence that 3-field lymphadenectomy is associated with improved 5-year survival, but it's related, but it's based on studies that have significant heterogeneity and lots of weaknesses. Also, with 3-field lymphadenectomy from the same group, they showed increased anastomotic leak rate and recurrent laryngeal nerve palsy with it. As you can imagine, doing that neck dissection will increase your chance of nerve. If you don't go into the neck, you won't injure the nerve at all. And years where anastomotic leak does increase, and it would do an extended lymphadenectomy. So we say that we individualize it, but a standard 2-field lymphadenectomy is usually adequate for most patients. And the survival difference may be due to stage migration, really, rather than actual true survival improvement. When you look at transthoracic versus transhiatal, we can use this meta-analysis from 2014, and they looked at overall 5-year survival, no difference. They looked at, and these were randomized controlled trials, they looked at pulmonary complications, significantly improved with transhiatal. So yes, if you open the chest, you're going to get more pulmonary complications. It's mostly related to the pain associated with the thoracotomy wound, because of the muscle aches they go through causes significant pain. But there was no difference in anastomotic leak or blood loss if you did transhiatal or transthoracic. Okay, so I think you're off the chopping block, Matt. For now, I'm going to finish off with. I saw something in the chat, but I think it was not for me. Okay, for feedback. Okay, I'm going to finish off with an algorithm for the earlier stage cancers that we're going to go for. It's not, we've gone through the diagnostic one. For the management one is the T1A lesions are still suitable for endoscopic resection. The T1B to T2, it will depend. Okay, if it's T1B, that is node negative clinical staging, then you can still go ahead and do an oesophageectomy. And if you then find an odd node resection with no lymph nodes, you can just follow the patient up clinically. If, however, you find the patient is either got nodes or it was not an odd node resection, or your clinical staging shows that it could be node positive, then you should give this patient neoadjuvant chemoradiation. And then this should be followed by surgery. Given that evidence, the adenocarcinoma differs slightly. It becomes a little more complex in the early stages because you can actually consider EMR or ESD for node negative T1B lesions in clinical staging. And if it stays that way, or even up to T1B SM1, then you can follow clinically up. But if it's node positive disease, then, and it's T1 early stage or T2 early node negative, you can do oesophageectomy for those patients up front. And if you've got no nodes and odd node resection, then you can follow up clinically. But any patients, once again, that has not an R node resection or lymph node should undergo adjuvant therapy. And if you've got a T2 lesion that is node positive on clinical staging, then they should have perioperative chemo. So the only difference here between adenocarcinoma and squamous is in squamous, you should give neoadjuvant chemoradiation. And with adenocarcinoma, you can give perioperative chemotherapy. So they just give the same treatment they would give for patients with gastric cancer. And then this patient is going to have surgery in between or after the treatment. I go into more detail about oncological therapy when we talk about locally advanced disease. And or when we talk about the more proximal cancers, and we talk also about definitive chemoradiation therapy. But like I said, that's a talk on its own. So for this talk, I only want to concentrate on the earlier lesions. Okay, so that's the end of the talk, and I would supposed to thank the ECHO and the ECHO India team for support, and feedback forms are available in the chat. Recordings are available, and thanks to the Gastro Foundation. Next week's talk on the 4th of April is by Dr. Colin Noel, which is classification, pathology, and diagnosis of pancreatic cancer. Are there any questions from this talk?
Yes, please.
Yeah, okay, sure, go ahead.
Thank you very much. That was really good. Just a couple of practical questions, if I may.
Sure.
How accessible are PET scans in your situation? Because we really struggle with waiting times there. I mean, ideally, everyone should be getting a PET CT, but I must be honest, on occasion, we go ahead without.
Yes, okay,
how's it with you?
If you go with the evidence, then everybody who, like I said, has got anything more than a T1 lesion and no evidence of metastasis on CT scan should have a PET. But we don't do it here. We don't practice it because of the availability as well. We have the same issue. So we just don't have it as available. It's available, but we can't PET CT every patient that we are considering for treatment because it'll just be too many. So the resources, yeah, it doesn't cope.
And then the high-grade dysplasias or T1As, I appreciate the EUS should be done as well, but I'm not that good at it. And I must say, I rely quite heavily on just an endoscopic lift. If it lifts nicely, I'll go ahead and take it out. I'm not sure, how are you doing them, or are you sending them away, or what is your setup of cases?
So we have EUS here at our hospital. It's still at the infancy stage, so we are sending our patients to Albert Tulia Hospital for our EUSs. But you can rely on the lift. It's very rare. I very rarely see a T1A lesion or something small. When I see it, it's more. They often come back as just polyps. But what I do at the time is this: I do assess. I send them for EUS, and then the EUS will usually say, no, it looks like a mucosal lesion. Then I will go for the lift, and I did notice that it looks quite easy, and I take that as an indication it'll come off. But there's not really good evidence for that. They will, if you're looking at evidence, and Matt maybe wants to say it in an exam, he has to say that what it shows is you should do the EUS because it should visualize the layers of the wall, and it should tell you whether you should go ahead anyway at all. So I think the exam answer should be yes, you should do EUS for them all. But practically speaking, one, we see them very rarely, and two, we are relying also on that lift.
And would you consider transhiatal, or are you doing yours 3-stage for a sort of a mid-thoracic thing?
Mid-thoracic, we don't do that. We do transthoracic for mid-thoracic tumors. The only ones we consider transhiatal are the distal tumors. So that means the tumors that are OG junction tumors, adenocarcinomas, we do transhiatal for, but we never do transhiatal for anything that we can't get above from the abdomen, because when you dissect the tumor itself, you must be able to see what you're doing. So in a transhiatal, you can't see, but we only take the normal esophagus out transhiatally, not the tumor itself.
But if you're doing a transhiatal, then you can't really do a 2-field properly. Or how are you doing? Are you doing a laparoscopic?
Yeah, then you don't get a 2-field. So like I mentioned, once again, the evidence shows 2 fields is the way to do it, but any lymphadenectomy, it's only going to tell you what the prognosis of the patient is. It's not actually going to improve the patient's survival, truly speaking, because if you remove lymph nodes, doesn't improve survival, truly. It's just a perceived improved survival, because it just tells you. So you still perform it, and the way we choose our patients is if it's somebody we think at high risk of pulmonary complications, then we don't go into the chest.
Thank you.
Yeah, because that's a risk-benefit thing.
Thanks, Lucien.
Sure. Any other questions?
Yes, Lucien, thank you so much. That was a really great talk. I wanted to ask you your views on minimally invasive esophagectomy. We didn't touch on that. But if you look at the stats, overseas, they're doing them almost all minimally invasive. We've started doing some, but I don't know, in South Africa, there's not many people doing it. Whether there's, and the latest thing now is to do them robotically, which I think there's not much evidence. But for my exam purposes, if someone asks me, you know, if there's benefit from the literature for doing it minimally invasively?
Okay, so if they ask you this, any level 1 evidence there is benefit from minimally invasive esophagectomy, the answer is no, there's none. And the reason for that is most of the studies done on minimally invasive, the vast majority, they are done in single centers as observational studies. And they're comparing it to historical controls. And they will tell you that these patients, they get out of hospital quicker. We used to do them open. Now we do them minimally invasive. And our patients are leaving the hospital 5 days earlier. And they're right. So it is better. But unfortunately, it's not from randomized controlled trials and even little alone a meta-analysis of, you know, randomized controlled trials that are of good quality. So there's no good evidence for it. But to me, I would say is you must do it if you can, but you must do what's safe in your hands. So they ask you an exam, would you try this on minimally invasive? They show your patient. Your answer would be no if you can't do it. But if you can do it or you have done, you say, yes, I'm quite experienced. I'm quite happy with it. So I'll do it. And so we are developing our minimally invasive esophagectomies here at our center. So we are doing more and more. But like I said, it's based on observational study evidence only.
Thank you.
Okay, anything else from you, Matt?
No, that was great. I'm looking forward to the next talk.
Yes, I don't know if I should do it again because, like I said, it's tricky. Not everybody does esophageal cancer, but I guess if you're going to be a fellow in GI, then you should know it, isn't it?
Absolutely. I think it's super important. It falls in between. No one seems to do it. The thoracics say they do it and then nobody, but I think it should be our domain. And I'm very much keen on another talk.
Okay.
I also think so. I think you need to do the advanced one.
Okay.
I think it's, I mean, that's what we see the most often, let's be honest.
Okay.
That
Okay,
would
so
be
that'll be the next talk then on upper GI from
That'd be
me.
nice. Yeah.
Okay, great. Thanks. Thanks, Karen. I think that's I'm finishing exactly before 5:30, so, like you asked. I hope,
Lucien.
I hope that's to your satisfaction. Yeah, I'm done now. Thanks.
Well, thanks very much. And thanks for everybody for coming in.
Okay, thank you, everybody.
Bye now.
Thank you.
Bye.